but my feet smell.
Okay. Keep
no sock shoes.
I know.
Hip replacement. We'll talk about surgical approaches to it. We'll talk about post-operative precautions. We'll talk about proper transfer techniques. We'll talk about proper exercises. These are things that you want to do in the immediate post-operative max protection acute care phase. Okay, so post-op day 1 up till about post-op day 10 to 12. So pretty long period of time. The 4 approaches are the anterior approach, the anterolateral, the direct lateral, and the posterolateral. The anterior approach does not release any tendon from bony insertion points. They don't cut through any muscle, okay? What they do is they make an incision between the sartorius muscle and the TFL. The leg during the surgery is in slight hyperextension. So the anatomical view that you're looking at is directly down onto the hip joint. They come in with their instruments and they pull apart. They do their surgery, they close back up. Some of the post-operative complications you can get with an anterior approach is femoral nerve palsy. So the femoral nerve innervates which muscles?
The quads.
And
The hip flexors.
the hip flexors. So you may have some gait abnormalities and stability from that. The anterolateral is a much more common approach. They also call it a Watson-Jones. Okay. Here, this is also called an MSS, muscle sparing surgery. Okay. They can do this surgery inside lining. They now go between the TFL and the glute med. So they go in that interval if you look where the muscles come down. The post-operative precautions for here are essentially the same, although some surgeons will not want adduction or internal rotation. But there is no flexion precautions. The hip joint has an anterior capsule and it has a posterior capsule. When a person dislocates, it's for 2 reasons. One is because the capsule wasn't repaired, or 2, because the muscles are still lax from the surgery, okay? The direct lateral approach is they cut through the greater trochanter. So they get down to the greater trochanter, and then they take a bone saw and they remove about a 50-cent size piece larger, about a $1 size piece of the greater trochanter. Hooked onto the greater trochanter that they remove is the gluteus medius muscle. They pull that away, do their surgery. When they put it back together, they have to take the bone and reconnect it to the other part of the greater trochanter. So, obviously, if you do active hip abduction, active, her muscle contracts. The contraction pulls on the bone that was now repaired. So if it pulls on it and it pulls it away, which it does, they have what's called an abductor mechanism weakness or an abductor mechanism avulsion. Okay? So you are allowed to do passive hip abduction. So you can passively move someone's leg into abduction to get them in and out of bed. The most common approach to the total hip is the posterolateral. They go in posteriorly, so you guys can see the incision, and sort of it gives away their approach. They remove the 4 short external rotator muscles away, and they release the posterior capsule. The reason that surgeons like this approach is because it doesn't affect the gluteus medius muscle. So these surgeons purport my technique's better because they don't have an abductor lip, the gluteus medius is strong, so there's no Trendelenburg. That's true. All that's true. But what happens if you think of the arthrokinematics of the hip joint with concave convex? If the surgeon doesn't repair the capsule posteriorly, not all do. It's their preference. If they don't tightly secure the rotators that they've taken down is a term that they released it with the scalpel. If they don't repair all that, as soon as the person's body weight drops down where their knee becomes higher than their hip, they can dislocate. So the dislocation rate's higher. So that's the 4 approaches. You guys follow that, right? Okay. You good? Okay. Exercises, what you can do and what you should do. For circulatory reasons, you want to have them do ankle pumps. Ankle pumps is simply plantar dorsiflexion. The veins lie underneath or deep to the muscle. So when someone has blood that clots and you actively contract the muscle, it's allowing the blood to come back up. So that's why you have to do that. You go up, you want to have them do quad sets. The term set is another word for isometric contraction. So she tightens up and relaxes. When you guys do this in the clinic or on my practical, I expect you to palpate. So you want to make sure that they're doing it properly. So the instruction is, push the back of your knee into my fingers. So now she has proprioceptive feedback. I have visual confirmation. I can palpate. That's correct. Squeeze your buttock muscles. I can palpate. I can feel the muscle contracting and relax. Squeeze your butt muscle together. So she's isometrically contracting. So those are things you want to do. Anterior approach, anterolateral approach, posterolateral approach, and the direct, all of them. You are allowed to do heel slides.
For quad sets, you want to just like have them hold for like 10 seconds each?
3 to 5 seconds. Is it going to hurt if they hold the contraction for 10 seconds? No. But why have somebody do something that's not going to be beneficial? So the longer they hold it, it's not any more beneficial. No. Heel slides. Your hand position should be as such. You have to support here, and you have to support here. They slide their heel up and down. A primary hip replacement, they're not allowed to go past 90 degrees. A lot of therapists freak out and they say, well, I don't want to have you go too far. Look where 90 is, guys. They're not going to get there, okay? So you want to have them go up and down like this.
So they can't do active?
They could do active. I'm just showing they should do active. So initially, they're probably.
So when you say they have to have their hands where you have them.
Oh well, what I mean by that is I want to support the weight of their limb in the 2 places of manual contact. One is at the ankle and one is at the knee. If I'm up here like this, come on up, she's unstable here. Okay, so I can be right here to support this coming up. And if she does it by herself, Brenda, I might just take my hand away and say do 10.
Okay, so there's
so
no...
they don't have to be active assistant. Okay. They can do it on their own. Anterior approach, anterolateral approach, posterolateral approach. 3 of the 4, they're allowed to do hip abduction. They should do hip abduction. You should. What's that? Active. Active. With the direct lateral approach, you don't want to have them do abduction. No. Okay? All right. Gastrocs, quads, glutes, post-op. Flex up here, hip flexors. If I want to do a short arc quad, I can use my arm. I can use my hand right here. I put my hand against her leg. Go ahead. I have one hand free now. Go. 1, 2. I can do this.
Long arc, right?
This is short arc. This is short arc quad. Well, okay, let's say she's from 30 from here to there. So long arc is more 90 to here. So maybe my angle was off. So maybe right here, up. So my hand here is taking the place of this or a bolster. This one. You could do it like this. Here, kick up. Short arc quad. Okay? You guys follow it. A total hip revision. A revision, their flexion is typically limited to how many degrees? 60. So they can do the same thing, guys. They have to do ankle pumps. They have to do quad sets. They have to do, you even want them to do hip flexion. But how far can they go? 60. So a good way to approximate 60 degrees is this. You take the contralateral leg, you passively bring her to 90. So I have her at 90 degrees, you guys see that? And then I'm holding her knee here, and I'm letting her foot drop down. So about right there, I'm gonna say, okay, Susie, bend this leg so your knees are equal. 1 and down. So now she has a visual reference of where she can go. Okay? Short arc quads, same thing. I'm here, she kicks out. Now, I don't have to give her resistance. The weight of her tibia is resistance. I could give her 1 finger. I can give her 2 finger resistance. It doesn't matter. Okay? You guys follow it?
Yeah.
Okay. Now, the bridges, I will teach somebody how to do a bridge if they've had an anterolateral, if they've had a direct lateral, if they've had a posterolateral. I'll teach them how to do it for the purposes of this. You've been laying in the bed, you know, I know you're in pain, you don't want to get out, you're in the bed 16 hours a day, you got to relieve pressure from your frail skin on your sacrum. Just lift your butt up in the air and down. And every half hour or so, just do 2 reps and that's it. She's too tired to go to the bathroom. She's dizzy from the medication. She's a fall risk. The nurse has to come in and try and get a bed pan underneath her. I might say, okay, and we got to get this pan underneath you. Can you go ahead and lift up? So I'm gonna do it for that reason. I'm not gonna rep her out. I'm not gonna say, I'm not gonna say, can you do 12 bridges? But I'm not gonna have her do that to strengthen her glute muscles in the first 10 days post-operative. Okay, yes, brother.
You didn't mention anterior. Can you do them with anterior? I know there's no hyperextension.
The anterior, there is no, if you talk to the surgeons, they'll say there is no post-op precautions in terms of don't move like this because you'll dislocate. However, some surgeons have reported that they've had patients who've dislocated when they do hyperextension. But it's rare enough and unlikely enough that they don't even make it a precaution.
Okay, so you could do bridges with any of them.
You could.
Okay.
Yeah, you could. I personally believe, especially in the first 14 days, less is better. Mm-hmm. They have a lot of swelling, pain, just get them going. Mm-hmm. Now, to get up out of bed, the rule of thumb is you get out on which side? Stronger or weaker? Stronger. So that would be this side. So that's too far. So I have it right here. So patients can get up on the same side as their surgery. What I want to avoid, if it's a posterolateral, a direct lateral, I don't want her to roll on her side. Roll towards me. If she rolls here, she can't dislocate because she's blocked against this table, but the compression of her body weight against the incision is too much. So I'm going to do this instead. I'm going to hold her leg. She has a good left leg. She has strong arms. Now I'm going to say, Susie, can you go ahead and sit up? And I'm just, can you go ahead and kind of do a little bit of a crunch and turn? So I'm controlling her leg for her, and maybe now she needs a little bit of help here. You know, I'm kind of supporting her leg, and then I'm coming down. And you got to be careful. This is where you got to be careful. Go back. So you got to be careful of when they're coming up. Go ahead. And that you don't do this here. So you got to be careful that you sort of keep them down and maintain this angle. Okay? You guys follow? Mm-hmm. Okay, and back up. Knee replacement. Knee replacement, you can have a unicompartmental, one side. If somebody has a bow-legged walk, they're varus, so which side of the knee joint typically is that going to affect? Medial. So they'll have a medial compartment, they'll have a medial unilateral replacement. If they're more in a valgus, okay, so now they'll have the other side, okay? So unilateral is just one side. Unicompartmental. Bicompartmental means femoral component and a tibial component. Tricompartmental means a femoral component, a tibial component, and then a patellofemoral. So under the kneecap, they'll put a little button in. So that becomes a new articulation there. If they do a MSS, that's a muscle sparing, or a MIS, minimally invasive. The minimally invasive surgery, you would think that the incision is only going to be this big. Minimally invasive typically means how much tissue, muscle, ligament, tendon are they infected. So somebody could have a minimally invasive surgery with an incision this long because they have a big, large, thick leg or they're real tall. But when they go into the joint, now they make a smaller cut and they're not disrupting the muscle. So the length of the incision that you visualize doesn't necessarily mean that it was minimally invasive or not. You guys follow that? Somebody can have a subvastus. So here right here is the VMO, vastus medialis oblique, okay? So when they go in, he makes his incision right here, another cut inside. He doesn't have to take the kneecap and evert it out to the side to get into the joint. He just makes the cut, moves it over, holds it there, then does the surgery. If they do a quad splitting, which is a traditional type of knee replacement, most surgeons do this. Make the incision through the quadricep muscle, evert to patella, do the surgery. You have a femoral component, you have a tibial component. The exercises are virtually the same. Ankle pumps, quadriceps, glutes, quadriceps isometrically, glutes, that's isometrically. Now I typically add in one more. I add a ham set. So a hamstring set. So basically I want you to bend your knee, dig your heel into the bed. So she's isometrically contracting her hamstrings. And relax. 1, hold, 1, 2, 3, relax. Dig in, hold, 1, 2, 3, relax. Okay? You definitely want to do hip and knee flexion with these patients. You have to get this knee moving right away after surgery. So whether it's assisted or not, knee flexion. You want to strengthen the glute med because we know that's important for gait. So patients can do this. Sometimes a patient can even do hip abductor strengthening But what did you remember about how do you have to support the knee? So if you roll on your side, on your left side.
Well, you can't have it. Yeah. You know, valgus or venous stress.
So if she rolls over here on her side, I have to support the weight of her knee because it's weak, her muscles are inhibited. I don't want to take my hand away on her new surgically repaired leg, take my hand away, gravity's pushing down. What do you think's happening here? What kind of stress? Valgus or varus? Valgus to the medial side. What ligaments remain intact with a total knee replacement? Medial collateral and lateral collateral. So she can have a brand new knee. She could be perfectly happy. Some therapist comes in and says, hey, Susie, go ahead and do this. And now she says, I am hurt so bad right here. Her knee swells even bigger. That therapist has just given her an acute MCL sprain. So you're very careful with that, okay? If you do strengthen, it's here. You're supporting the leg when you do this, okay? Very good. Go back.
I may have to go soon. You might need another volunteer.
I'm almost done.
Okay.
So another thing that you can do, if somebody doesn't have any hip pathology, she has a bad right knee, she was a dancer, she got an accident, she tore up her right knee, but her left knee's fine. But over the years, she's also got her hip hurting. So if when she does a straight leg lift to work her quads and her rectus femoris muscle, if she does this, how much compression force is going through that hip joint? Quite a bit. So she might not be a candidate to do this straight leg raise. That's fine. So you have to figure out whether a person can tolerate that. If she is, then I'm going to have my patient do some straight leg raise, but I'm supporting the knee joint. I'm not taking my hand away. I'm supporting the knee joint. You guys follow? The last thing is that the muscle that typically gets overlooked, doesn't get worked as much as it should, is this tib anterior. So I always take a TheraBand and have them do resistive dorsiflexion, okay? The last thing I want to tell you guys is that with a knee replacement, you never want to have a patient put their knee in this 20 to 25 degrees of flexion, which is the open pack position. It allows a fluid or effusion to accumulate here. You have an incision that is not in the best line of stress for healing. So you want the knee left straight. As time goes on, you eventually want to have your patient do this here. Now gravity is allowing pressure to go through the knee joint. They also call this position the knee sag position, sagging down.
So how soon after surgery would you put them
in this position? No sooner than post-op. Me personally, no sooner than post-op day 5. If anything, I have them here, and I might have one towel, so they're up like this, right there. But I'm not having that much pressure on their posterior capsule at that point. It's just too much, in my opinion. Okay, so these things should come really, really quick on your clinic, on your practical and then your clinical. Any questions specifically about the hip and knee that I can answer? And this isn't cute. This is max protection. When you go to 2 to 4 weeks out, their sutures and their staples are going to be removed. Now they can be a little bit more aggressive. Okay. Also, let me just finish up my thought. I got 5 more minutes and I'm done. I'm going to have Susie stand up. Tim, can you grab me a walker real quick? These next exercises I'm going to show you are also things you can do with your total hip and total knee patients in the first 0 to 10 days. So these are also allowed. If she's a right hip replacement, I can have her lift her right leg up against gravity. So go ahead and up. 1, 2, 3. So this is another way that she can strengthen this muscle, which is the same thing as she's laying flat. I just now put the femur to gravity. You guys follow? If I say work your hamstrings and she bends your knee, go ahead, bend your knee back. No, bend your knee back. Yeah, but no, I'm sorry, just bend your knee. If I have her do this here, I'm gonna wanna bring her leg back a little bit like this, put her in good position. Now I can focus on her hamstring. If she's forward, now flex your knee. That doesn't put the hamstring in the best position to strengthen. I want her extended, now do it. You guys follow? Okay? Typically, I'm gonna have my patient alternate. Left, right, left, right. So march. Okay? Bend your knee, alternate kick. Okay? Alternate, side kick. That's okay to do for everyone except the direct lateral approach. Go up and down on your tiptoe and back on your heel. Anterior tip, gastroc. Like this. Up here and back. Okay? And I can also work on sit to stand. So now, patient's here. She comes forward. Watch your ankle. So I make sure she doesn't lean this far forward. I have her at 90. If the precaution is 90, and I'll say go ahead and stand up. And then down. I'm doing this post-op day 1 all the way to 10. Now, I'm going to only do 3 to 5 reps, but I'm initiating it. Okay? What I'm not doing, I'm not stretching her hip flexors. I'm not stretching her quads. I'm not stretching acutely inflamed muscles. Because this is going to make it more inflamed. Okay? You guys follow? The biggest thing is that for a knee replacement, please walk over, is have a seat. So the biggest thing is I'm going to have her work on knee flexion. So if you can slide your knee back and then hold it there, and now scoot your body forward. Scoot more. So now I have her hold that position, maybe 5 seconds. 1, 2, 3, 4, 5, go back. So even though her knee joint is swollen from surgery, the 5-second hold is not going to traumatize that tissue as if I had her hold it for 20 to 30 seconds, and if I'm manually flexing. Okay? Thank you. I think I covered everything. You guys have any specific questions that I didn't answer?
I had a question about one of the test questions.
Yep.
That's okay.
Well, you can, we'll let Robert stop this.
Okay.